Okay, we are live.
Hey everyone, welcome back to another session. Today we have Dr. Katie Lee, and she will be sharing a bunch of tips, cases, and anything else that we might find helpful. So whenever you're ready, you can take it away.
Hi everyone, thanks for joining tonight. I am Dr. Katie McCann Lee, and I am a dentist, a general dentist out of Denver, Colorado. I've been practicing since June of 2010, so I have 11 years under my belt right now. I'm just going to forewarn you, I have 3 dogs that are right outside my door, so you may hear them trying to bang to get in here. So hopefully they'll behave, but I can't promise it. So let me go ahead and just start sharing my screen here. Alrighty, are we good? Okay. All right, so I feel very honored and privileged to be part of this this webcast tonight. So thanks for having me. So like I said, I graduated in 2010. I went to dental school at University of Illinois in Chicago. I also did my undergraduate studies at University of Illinois in Champaign-Urbana. Graduated there in 2006, and then dental school in 2010. Right after school, I decided to move to Colorado. The plan at the time was to live in Colorado for 2 years and then to go back to purchase my hometown dentist practice. I'm from a super small town, so there was only one dentist in our town, and I was going to purchase the practice from him when he retired. And I moved out to Colorado and kind of never left. So I do partner with an organization called Pacific Dental Services, which is a dental service organization that handles the business entity of the practice and then allows me to focus on patient care and developing and coaching my doctors. So currently I own over 85 practices with Pacific Dental Services. I'm the clinical director of 5 regions. The regions are Colorado, Idaho, Utah, New Mexico, Georgia, Central Florida, and South Florida. And really what I do is I try and focus my coaching and mentoring on new graduates. I personally love new grad dentists because I feel like they are the most excited for what's to come, and I feel like they're the easiest to coach and mentor with new techniques. So definitely love new graduates. I've also developed a guided surgical implant course for Novo Biocare on the placement of dental implants by general dentists. So I do travel around placing or teaching those courses. I was just in New Mexico last weekend teaching a course, which is great. And then I am on Instagram. That's my Instagram info, and then my website info as well. On my website, I have things like I have a leadership blog that helps dentists with leadership and kind of issues that they're having in their office. I also have opportunities for coaching and mentoring young doctors. And then I also post a lot of really great case information. So my journey to becoming a general dentist. So this was me back in 1998. Again, I grew up in a super small town. There's only about 5,500 people there. And so I grew up riding 4-wheelers or ATVs. And on July 5th, 1998, we got home from boating that day. I was still in my swimsuit, actually. And I decided to go for a ride on the 4-wheeler with my friend here, Carrie Jo. And we ended up, I didn't wear a helmet. That was actually the only time that I was on the 4-wheeler without a helmet. And we ended up crashing into a telephone pole. So I went head first into the telephone pole, no helmet on. We were going about 35 miles per hour. I ended up losing several teeth. My lip was ripped off, which you can see in that photo. They stitched it back together. I had fractured almost every bone in my face from my eyebrows down. My eye socket was shattered, and I broke my jaw. My jaw was kind of mangled. I also broke my right wrist. So it took 4 years and 9 reconstructive surgeries to fix not only the aesthetics of my face, but more importantly, the function of my jaw. I had my jaw wired shut for 8 weeks and got really, really skinny, which you can see in those photos. And when I went to get my wires taken off, the surgeon said, okay, go ahead and open your mouth. And I went to open my mouth and my jaw was completely locked shut. So what had happened was my jaw joint had fused closed during that time of healing. And the surgeon said, I don't know what else to do. Best of luck. So, and he was actually the oral surgeon for the University of Illinois sports team. So he was a very respected oral surgeon, but unfortunately my case was a little out of his scope. So it took 4 years and 9 reconstructive surgeries to be able for me to even open my mouth enough to get a toothbrush in. So it wasn't until my senior year of high school that I was able to finally open my mouth enough to put a toothbrush in and then finally get to restore my teeth. So you can imagine having your jaw wire shut for that long. I had broken teeth from the accident, missing teeth. So I wasn't able to brush or floss. And then after having my wires cut off, I still couldn't open for about another 3 years. So my teeth really suffered during that time. And I also had to wear fake teeth in the front because I was missing several front teeth. So I essentially joke about it now, but I had to wear dentures all through high school for upper and lower teeth. So I really got to understand and experience the value that your smile gives to your self-esteem and your social interactions. I also got to understand, what our patients go through when they don't have teeth and they can't function, they can't chew their food. I essentially went from 130 pounds, which is what I weigh, down to 98 pounds. And my liver was shutting down, my kidneys were shutting down because I couldn't get proper nutrition. So this photo on the right, actually with my face being asymmetrical, this was right after my rib graft. So what they had to do in order to open for my jaw to be able to work was they had to take my rib bone, take out my condyle, shape my rib bone to form a jaw joint. They put that in, and then they also used cat cartilage to make a TMJ disc. So it was a lot of surgeries, but this was one of my last surgeries that I had so that I could open my mouth. So I always tell people, if you find your why, you'll find your way. So I'm very passionate about dentistry because I experienced this horrific accident that really showed me the value of what it is to have good oral health and a smile that you can interact with people. So what is general dentistry? So I actually love general dentistry because it can be whatever you want it to be. When I was in dental school, I had very good test scores, very good grades. I graduated number 2 in my class. And everyone kept saying, what are you going to specialize in? And I said, I don't really want to specialize in anything. I'd like to do it all. Because when you're a specialist, you can only focus on that one thing that you can make your craft or be an expert in. I tend to like to focus it on whatever I want to do. So I can do bread and butter dentistry, meaning crown and bridge, CAD/CAM restorations. I can do implants, which I did a bunch of implants today. I can focus on cosmetic procedures such as veneers and crowns for patients. I love doing Botox and fillers for patients. That's kind of a fun side thing that I do. I also treat sleep disorders such as obstructive sleep apnea, and that definitely ties into TMJ disorders and TMJ pain. So I do work with board certified sleep physicians to treat those patients. And the main thing that my practice focuses on is the mouth-body connection, which is what I'm going to talk about today. The mouth-body connection is definitely where we're moving to in healthcare. And I know in dentistry, a lot of people are talking to you about the teeth. So today I want to just spend a little bit of time talking about something of where I think we're going to be going in the future. It was great because yesterday I had the privilege of seeing a little kid, I think he was 7 or 8, and I got to do a pulp and stainless steel crown, which I haven't done in 4 or 5 years because most of my procedures are big implant surgeries. So I got to do that yesterday, and then today I had a sedation case where I put a patient to sleep and we redid her whole mouth with crowns and implants. So that's the great thing with general dentistry is you can make your days whatever you want them to be. So some advice for college. I remember what it was like being a pre-dental student, and it kind of always seems like the end will never be here, right? You're just kind of going through the daily grind. And especially with COVID, I know you guys have had it really hard the past, year and a half. But a lot of people would tell me during school, oh, you don't have to study that hard. D's still get degrees. And I never really believed in that, because I feel like if you are going to put the money into getting a great education, you should do whatever you can to learn as much as possible. So don't follow that mindset of D's get degrees. Study hard and try and learn as much as you can. I always tell, young doctors or young students as well, is practice everything. So when you do get into dental school, make sure you're timing yourself on your preps. Make sure you're increasing the speed of which you're treating patients. If you have the ability now to shadow, which I know you guys haven't had that yet, which is why we're doing this today. But as soon as you can get in and start to shadow, get in and try and experience anything and everything you can. I originally set off to dental school because I wanted to be an orthodontist. We had a great orthodontist in our town who was really social with everybody. Everybody loved him. And when I went through my accident, I had to have braces on twice for a total of 4 years so that they could move my teeth, so that they could refracture my jaws and reset my bite. I had my jaws refractured twice, actually. So I went into dental school thinking I wanted to be an orthodontist. Well, I went and shadowed him one day, and I was on the other side of the chair. I've always been a patient, but I was on the other side of the chair, and I realized, for ortho, for me, is not what I want at all. I want to be the one with my hands in the patient's mouth. I want to be caring for them. So make sure that you are getting as much exposure as you possibly can at this time. Really work on your communication skills with other people. I think this is the number one thing that is undervalued. Whenever we're going through school, we always think we need to learn the science and we need to learn the procedures and the techniques, but no one will care how good of a dentist you are unless you're able to communicate properly with them. So whatever you guys can do right now to start learning better communication skills, I would really encourage you to do that. One of my biggest regrets is I think I went through my entire schooling without ever taking a business class or a communications class. And I hope you guys aren't making that same mistake now. I've learned everything on my own afterwards, but it would have really been great to have those foundational skills. When I was in college, I was focused on science and math and physics and, all of those subjects. And I really didn't put any effort into learning communication or business skills then. Also, really start focusing on your leadership development. So this is another thing that was really eye-opening for me, is that you can be a great dentist, but if you want to be able to treat more patients, which has always been my goal, I want to improve the health of other patients, you really need to make sure that you are able to lead a team and work with a team. Growing up, I was always very individually focused, singularly focused. But when you get into the field of dentistry, you're only as good as the weakest member on your team. So if you want to be able to provide a great experience for patients, if you want to have a successful practice, then you really need to begin to learn how to lead teams. I mentioned this earlier, seek outside information. When you guys get into dental school is not the end all be all, right? And you guys are learning that in college right now too. There's so much more information that your peers will have that have been practicing for a long time. So find a mentor outside of your dental school, your college. If you guys could find a dentist right now that you could go work for or shadow or whatever, that would be really beneficial down the road. I actually was a dental assistant for 6 years before I went to dental school for the dentist of our hometown. And so I felt like by the time I got to dental school, I pretty much already knew how to do most procedures just from watching him treat patients day in and day out. And then this is my favorite quote: stay humble and stay hungry. This is very important for your development. The further you get along in school, sometimes it can be an ego boost of, hey, I'm almost there. I'm almost, going to be a doctor. But I'll tell you, the further up you go, the more you realize that you don't know everything you think you do. So make sure that you stay humble and make sure you stay hungry to keep continuing to improve. So what does a typical day look like in my practice? So my main office that I work at, there's two main practices that I see patients out of. And my main office is in Aurora. It's called Aurora Modern Dentistry. I have 3 general dentists, 2 hygienists, and I typically have a specialist in office 2 to 3 days a week. So I have oral surgery, a periodontist, and an endodontist that come in to help me with my patients. And we run our schedule from 8 a.m. till 7 p.m. Monday through Thursday. We run 8 to 5 on Fridays, and we run about 8 to 3 on Saturdays. In the past, before COVID, I actually worked a Sunday shift, which I found insanely satisfactory, because then I got time off during the week to go snow skiing, which I love being out here in Colorado. You know, one thing I hear a lot from newer dentists or dental students is they say, you know, I'm getting into this for the lifestyle, right? I don't want to be a medical doctor because I want to have a good work-life balance. You absolutely can have a work-life balance, and I encourage it, but also know that that work-life balance doesn't necessarily have to be that you work from 8 to 3 every day, right? So my Monday schedule, I typically work 1 to 7. My Tuesday schedule, I do 10 to 4, and then the rest of the week I do 8 to 2. So you can shift your hours any way you want. You just want to make sure that you have availability in the practice to see patients. Especially COVID and after, a lot of patients are struggling to find jobs. They have to go back to work. They're not having the time off that they did in the past. And a lot of people are strapped financially, so they don't want to take time off of work to come into the practice. So it's really important that you are empathetic to that and have access to care for your patients. So that's why we're open until 7 every day of the week. I personally run 4 columns of patients. So I have 2 columns to see new patients and production treatment, such as crowns, root canals, implants, extractions. And then I see 2 columns that I have my continuing care or recall patients in, and non-productive appointments, such as denture deliveries or bite adjustments. I typically aim to be above $5,000 in production a day, and that's just for me. So typically I want to see my daily production between $6,500 and $7,000. But if a doc can run about $4,500 to $5,000, that's usually very good. My sweet spot for a number of patients that I see is 10 to 12 per day. I personally don't like to see more than that, because I feel like I'm running around in circles and not getting to spend quality time with my patients. So I typically will stay around 10. Some doctors in my practice do better with less. So I have one doc that likes to see 6 to 8 patients a day. And then I have another doc that likes to see a lot more. So she sees about 15 patients a day. But everybody has a sweet spot of to where they can feel productive and where they feel like they're still getting valuable time with their patients. So that'll be different for everybody. I like to do all procedure types. So just what I mentioned earlier, yesterday I did a pulp and crown on a kid. And then today I was doing 2 implants and a full mouth of crowns on a sedation patient. So I don't save certain days for certain procedures. Whatever walks through my door is what I treat. And so we really focus on same day dentistry in my practice, because again, a lot of patients don't have the ability to take time off and come back for multiple appointments. So if a new patient comes in and let's say they need scaling, root planing, a crown and a filling, we're probably going to do all of that in one visit for them. So we like to focus on same day dentistry. So what kind of problems do my patients present with when they come in? So the number one thing that I see in my practice on a daily basis is oral inflammation, periodontal disease, gingivitis. That is number one. I've also been preaching for years that inflammation is the root cause of all major diseases in the United States. Cancer, heart disease, Alzheimer's, diabetes, rheumatoid arthritis, inflammatory bowel disease. These are all inflammatory diseases. And because inflammation is the root cause of all major diseases, that's why I'm going to talk to you today about the mouth-body connection, because it's so important where we're moving in the future, or where dentistry is going. We're no longer just tooth mechanics, right? When I graduated in 2010, there was a paper that came out that said there is a link between periodontal disease and heart disease. Just a link, nothing causal, no major evidence of what the link was. They just said that there's some link between inflammation in the mouth and inflammation in the arteries. What we now know is that it's definitely bidirectional. We know for 100% certainty that bacteria in the mouth do not stay in the mouth. They circulate throughout the body. We know what bacteria causes what damage in distant organs. And we also know how to treat it. We can take certain kinds of objective tests, such as saliva tests and enzyme tests, to see if there's oral bacteria anywhere else. So the mouth-body connection is very, very important, and I would encourage you guys to start reading up on it now. That way you'll be way ahead when you get to dental school. So inflammation is responsible for the leading causes of death. So the number one cause of death in the United States is heart disease. The number two cause of death is cancer. And then we have lower respiratory diseases such as COPD, stroke, Alzheimer's, and diabetes. I'm getting ready to speak at the Florida Dental Convention next Thursday it's called The Monsters in Your Mouth. So it's the bacteria in your mouth and how it affects all of these diseases that I'm mentioning now. The very next day, on Thursday, I'm going to be recording, or on Friday, excuse me, I'm going to be recording another webinar with Dr. Massley, who is the world expert in Alzheimer's disease. And the reason we're having that conversation is because the number one cause of cognitive decline is insulin resistance. The number two cause is oral bacteria. So very, very important stuff that we're going to be going over. So what are the causes of inflammation in the oral cavity? So we have endo abscesses. We know that those are very, very dangerous to overall health. I'm sure some of you had actually seen the documentary on Netflix saying that root canals cause cancer. You know, that was actually later taken down because there was no proof to what they were saying on the documentary. But what we do know is that endo abscesses are very dangerous to our health. The reason we know that is because a lot of times when something is wrong, we have a symptom associated with it. We have pain, we have heat, we have swelling. The problem with endo abscesses is if the tooth's already been root canaled, sometimes the patient won't have any pain. So they could have this silent infection going on for a very long time that bacteria has entered the bloodstream and is causing damage in remote locations. So endo abscesses are very dangerous. We also know that karyogenic bacteria, so the bacteria that cause cavities, such as strep mutans, cause inflammation. And then, of course, the periodontal bacteria cause inflammation. Another big one that you guys should start looking into is obstructive sleep apnea. So 80% of adults that have sleep apnea are actually undiagnosed. So it is the deadliest undiagnosed disease that we have in America right now. And a lot of people think that sleep apnea is just for people who are obese. And that's not true. The majority of patients with obstructive sleep apnea are postmenopausal women. So it's very important that we are looking at risk factors as dentists, such as restricted airway. We can see that by looking in the patient's mouth. We can also look for signs of tooth grinding. We can look for signs of acid reflux in their mouth. And then we can also see signs of obstructive sleep apnea on 3D CT scans that we can take in our offices. So untreated sleep apnea is actually more dangerous for your health than smoking cigarettes. That's why people have heart attacks and strokes while they're sleeping and they never wake up, is because they actually stop breathing, and that lack of oxygen causes them to have a heart attack or stroke. We also know that there are more fatal car accidents every year due to untreated sleep apnea than there are from drunk drivers. So obstructive sleep apnea is something that's very, very harmful to the body, and it's something that dentists can help treat and recognize as well. So I mentioned earlier, bacteria in the mouth do not stay in the mouth. I say this to my patients all the time. What's showing in your mouth is a symptom or a manifestation of what's happening elsewhere in the body. So if you have an unhealthy mouth, you also have an unhealthy body. This is a very interesting statistic. 50% of all heart attacks and strokes are caused by oral bacteria. So that's either periodontal bacteria, so gum disease bacteria, or bacteria from endoabscesses. Now, what's interesting about this is of the people who died of heart attacks and strokes, they've actually analyzed the blood clots in the people that died, and 70% of the clot makeup was oral bacteria. So not only does it cause heart attacks and strokes, it also increases your chance that they're fatal. So again, we have a very, very important job at getting our patients' mouths healthier. So heart disease is the #1 cause of death in America, and early intervention is the key to living a long life. So what happens here and how the bacteria get into the bloodstream? So if we look over at this picture, what this is a picture of is showing the plaque and tartar buildup that's on a patient's tooth and their root surface. That bacteria that's on the tooth and root surface actually secretes enzymes and proteases that go and actually create ulcerations in the patient's gum tissue. Once those ulcerations happen, the bacteria then can invaginate those ulcerations and get into the little capillaries and circulate throughout the bloodstream. So again, the bacteria in the mouth do not stay there. This is a book that I read right when I graduated dental school and I started practicing. So I would encourage you guys to read this now. This is called Beat the Heart Attack Gene, and it's written by Dr. Bale and Dr. Doneen. They have a clinic in Washington where they give 100% money back guarantee that if you are a patient of theirs and you have a heart attack or stroke while you're under their care, they'll give you all of the money back that you've spent while under care with them. The reason they do that is they focus on lowering systemic inflammation. So the old mindset of what causes a heart attack is you have plaque in your arteries, the plaque builds up over time and occludes the artery, and the artery has no more blood flow, and then you have a heart attack. That's actually not true. And the reason we know that is true, but that's not why we have heart attacks. And the reason we know that is because you can have plaque building up over time into your blood vessel, and then your heart and your body can actually make new accessory blood vessels to go around that blockage to keep blood moving. What happens when we have heart attacks and strokes is we have the plaque build up, and then inflammation happens and it actually rips open the blood vessel. When the blood vessel rips open, that's when all the clotting factors come to try and stop that bleed, and that's what occludes the vessel, and that's why we have heart attacks and strokes. So very important to read. And what was shocking is, again, back then when I was graduating, dentistry and medicine were completely separate entities. These were the first people, being medical doctors especially, that talked about the link between oral health and systemic health. And they have an entire chapter there, I believe it's chapter 4, I remember it to this day, where they talk about the bacteria in the mouth don't stay in the mouth, and how endoabscesses and perio bacteria cause heart disease and heart attacks and strokes. So I would definitely encourage you guys to read this book so you'll be ahead of the curve. So we know that Perio-pathogens, so gum disease bacteria, contribute to atherosclerosis or heart disease. So heart disease is a medical condition with a dental solution. So this is why physicians and dentists must work together. Any patient that's in your dental practice that is showing signs of gum disease, it's our job as dentists to educate them about how it may be affecting their heart, brain, and diabetes, and see if we can get them to their medical doctor to get a workup. If they don't have a medical doctor, then we need to help them find one. So what we know now is evidence supports that gum disease is independently causal to arterial disease. We now can test for bacteria in patients' mouth, and what we found is that patients who have the bacteria AA, PG, TF, TD, and FN, that those bacteria are directly related with causing inflammation in the blood vessels. And it's a very easy saliva test that you can do in your practice. We also know that gum disease pathogens cause diabetes. So 40% patients have a 40% increased risk of having diabetes if they have gingivitis. That's a big increase in risk factor. If their gingivitis has progressed on to perio disease, so the difference between gingivitis and gum disease is that gingivitis is where the inflammation is localized to the gum tissue. That's completely reversible. Once that has not been treated, that inflammation from the gum tissue can move down to the bone and will start destroying the bone away from around the teeth. At that point, that's when the bacteria are in the bloodstream. Gum disease is not curable. We can only manage it and keep it from getting worse. So if someone has gum disease, otherwise known as periodontitis, they're at a 50% increased risk for diabetes. If someone is missing all their teeth, they still have a 30% risk factor for diabetes. And for people who have advanced gum disease, they're pretty much guaranteed to have diabetes as well. So this is what I'm going to be talking about next week, is the way that oral bacteria contribute to brain health. So a lot of people have been saying for years that Alzheimer's is essentially diabetes of the brain. So what we know over time is that in people with dementia or Alzheimer's is a type of dementia. What happens is we get these beta amyloid plaques that start distributing in the brain. It also causes the brain to shrink. So you have a healthy brain on one side and then the Alzheimer's brain on the other side. And what we know is that the bacteria in the mouth cross the blood-brain barrier and will increase the risk of getting Alzheimer's disease. And the reason is because we're increasing inflammation in the brain, and that's decreasing the amount of oxygen that gets to the brain. And so we're essentially starving our cells of oxygen and glucose as well. So patients with gum disease are 2.6 times more likely to develop Alzheimer's disease. We know that the bacteria PG, P. morphus gingivalis, is directly related to crossing the blood-brain barrier and causing Alzheimer's. That same PG bacteria is also indicated in heart disease, so that's why they're all related. So very important new information we're getting there. Another great book to read is Dr. Masley's book. It's called The Better Brain Book. And that talks a lot about Alzheimer's, how to prevent it, and also oral health. So this has been a newer one. We now know that gum disease pathogens contribute to different types of cancer. So P. gingivalis, there's that bacteria again, right? That's causing heart disease and Alzheimer's. And AA were associated with an increased risk of getting pancreatic cancer. That's very scary because pancreatic cancer usually isn't caught until end stage. There's really no signs for it, and it's very hard to image it and detect it until it's already grown and metastasized, unfortunately. Another type of cancer that is directly caused by oral bacteria is FN and colon cancer. So about 20% of all colon cancers are directly linked to FN bacteria, which is in the mouth. And this has long been stated here that gum disease pathogens can definitely affect baby outcomes, pregnancy outcomes. And the bacteria associated with this is FN, the same one that affects colon cancer. So FN crosses the placenta and affects the health of the baby. So if a mother has periodontal disease, she has a 30 to 50% higher risk of giving birth early or having a baby with low birth weight. We also know that FN causes stillbirths. So majority of stillborn babies, if there's no other cause such as trauma or something like that, it's directly related to FN bacteria, and they can test for that. So what can we do to run some tests and detect these early pathogens in or detect these periodontal pathogens in our patient's mouth? So one thing that we should be encouraging all dentists to do is to probe every cleaning, every time the patient comes in. A typical standard of care for dentists is to probe once a year for healthy patients and every 3 to 6 months for patients that are on a periodontal maintenance protocol. What we've done in my practice is any patient who has their adult teeth, which means 12 years old or older, we probe them every time they come into the practice. The number one thing that dentists get sued for is not being told that they have periodontal disease. So what happens is a patient's been a patient at their practice for decades. Their dentist stops probing their gum. So what probing is you're actually going in and you're measuring the distance between the gum tissue and the bone. We have a certain measurement for that, that's 2 or 3 millimeters, that tells us that the gum tissue is healthy. If the measurements are higher, so 4 millimeters, 5 millimeters, 6 millimeters, it can go all the way up to 12. If it's higher than 3 millimeters, that tells us that either the gum tissue is inflamed, which is reversible, that's gingivitis, or that the patient has gum disease where they're losing bone around the teeth. So we need to be checking those measurements every cleaning, every time. So what happens in those lawsuit cases, it's because patients have been a member of a practice for several years and the dentist stops probing them. And over time, the oral health can change in as little as 90 days, the research shows. But because they've been healthy in the past, they never think to reprobe them. And then the patient switches dentists, maybe they move or maybe their insurance changes. And the new dentist tells the patient, hey, you have periodontal disease. And the patient goes back and sues the original dentist. So it's very important that we're always screening for gum disease in our practices. This is one thing I was talking about earlier, the oral salivary diagnostics. So these are actually objective tests that we can do for our patients that will give us the bacteria that's in the mouth, the level at which they're present, and then also we can test for interleukin 1 and interleukin 6. Those are inflammatory proteins that if a patient has a mutation in those interleukin genes, it automatically predisposes the patient to having a higher inflammatory response to any kind of bacteria in their mouth. So let's say that, I'm 37, I've always been pretty healthy, my teeth look pretty clean, but when my dentist is doing my exam, he or she is noticing that even though my pockets are measuring healthy, so 2s and 3s, I'm bleeding a lot, right? Bleeding is not normal. We don't want any of our tissues to ever be bleeding. So my dentist may order a bacteria test and a genetic profile to see if I'm at increased risk. Most likely, I probably have a mutation in one of these interleukin 1 or interleukin 6 genes. If that's the case, this means that whatever bacteria is in my mouth, I'm going to have an exaggerated immune response to, and I'm going to have an increased level of inflammation. That also means if I have an increased level of inflammation in my mouth, I also have it in my heart, I have it in my brain, I have it everywhere else. So it's very important for us to know if our patients are predisposed to inflammation. Because if they are, that means we need to be more closely monitoring their healthcare and their oral health care and making sure that we keep them from getting systemic infections. There's another type of testing that I started doing in my practice about 6 months ago. It's called alpha MMP8 enzyme testing. This enzyme is actually present throughout the body, and what it does is it breaks down collagen, or breaks down our connective tissue. So we have this in our heart muscles, our brain, pancreas, you name it. We have this enzyme everywhere. And the higher this enzyme is, the higher levels that this enzyme is present, means that the more tissue breakdown and inflammation we're experiencing. So this test is really great because I can tell a patient chairside in about 4 minutes if they're currently experiencing gum and bone loss due to elevated enzyme levels. So it looks like little pieces of litmus paper that I can put down in the pockets, and that will tell me if the patients are experiencing gum disease in this moment. And what's really great about this is in the past, we've only really ever been able to do subjective tests for patients for gum disease. So essentially the probing, the measurement of the gums. And it is kind of challenging sometimes to get patients to believe the measurements or believe what you're telling them, because they'll say, oh, well, you just pushed too hard when you were measuring. So now it's great that we've joined the medical field and we've actually got objective tests that will give us data to tell the patients if they have an infection or not. So again, early intervention prevents long-term destruction. So very important to catch this stuff early. Ideally, we should be catching these infections, catching these enzymes, catching these genetic mutations, treating our patients appropriately so that hopefully we can prevent any kind of long-term tissue damage. So this is the Salivary Diagnostics technology that I use. It's called Oral DNA. And this test packet actually has 4 different tests. The Perio path is just tests for oral bacteria. What's really great is it'll tell you what bacteria are present. It'll tell you what levels they're present. And it'll also tell you if that bacteria is affecting distant organ systems. So that's really cool to talk to your patients about. The Alert 2 test, it talks about the patient's bacteria as well as their genetic profile of their interleukin 1 and interleukin 6. I can also test for HPV doing this, which is very great to be able to do. The number 1 cause of oral cancer is HPV infection right now. 80% of adults are infected with HPV at some time. Most of the time it resolves and patients don't even know that they had it. But 80% of adults have HPV at some point. And we know that HPV is the singular cause of cervical cancer. And it's now the number 1 cause of oral cancer. When I graduated 10 years ago, the number 1 cause of oral cancer was smoking. Well, now smoking has declined and HPV is rising. And what's really scary is HPV, it's affecting the younger population. So we're seeing cancers pop up in people who are 35 to 45 versus seeing, smoking type of cancers that typically will show up around 60 to 70 years old. So we can do a saliva test to see if the patient has HPV. And then we can also do a test for strep mutans, which is the bacteria that causes cavities in patients' mouths. So if we have patients that are coming in, let's say I had a kid in the office, he's starting to get a couple cavities here or there, but his mom maybe has a lot of cavities. We know that when you're born, you're actually born with a sterile mouth. So the only way that you can get cavities is having it transmitted to you from something else, whether it's kissing a relative or a boyfriend or a girlfriend, sharing drinks with someone, sharing food with someone. That bacteria is not native to our mouths when we're born, so we can test for that too. So this is an example of what I would get back from an oral DNA profile. So this is a fake patient, so we're not disclosing any information, but it's going to break down the bacteria that's in the patient's mouth into 3 categories. One category is the high-risk bacteria, and what that means is that patient is at an increased risk for having gum disease, but also significant heart disease or heart problems. The moderate risk bacteria, these are going to be more of your chronic long-term bacteria that are causing gum disease, and this is going to affect a lot of long-term disease such as diabetes, Alzheimer's, arthritis, things like that. And then we have our low-risk pathogens. There's 2 now that we actually test for, but this one has 1 test. And this is actually going to show us the patient's home care. So if the low-risk pathogens are really high, then we know that the patient's not doing a good job at their home care. So if we look at this, we also see those black dashes on the screen. Those dashes are the thresholds that in most patients, if someone is higher than that black dash, the threshold, then they're currently damaging distant organs and also losing gum and bone. Now, we also have to take into account that if a patient has a genetic mutation, so let's say they have a mutation in IL-1 or IL-6, that means they're already starting at an inflammatory level. So now these threshold levels don't matter anymore because their thresholds are going to be much lower, if that makes sense. So this report will tell us what bacteria are high, and it'll give us some information about it. So again, if we look at P. gingivalis, we see there that it's transmittable, meaning if I have P. gingivalis and my husband does not, and I kiss him, I can transmit my bacteria to my husband. I also see that it's tissue invasive. And so we talked about it on a previous slide of how the bacteria get into the bloodstream. So this bacteria likes to burrow into the tissues and circulate throughout the body. That's why it's so damaging in Alzheimer's and the heart. And it's also associated with aggressive form of disease. So this is really a great tool to talk to your patients about. And there's really not that many practices that are using this technology, and it's a shame. So I would definitely encourage you guys to look into this when you get into dental school. So when we have oral DNA, and we have a patient with a gum infection, whether it be gingivitis, which is curable, or periodontal disease, excuse me, the way that we typically have treated gum infection in the past is by doing something called a deep cleaning, which is essentially where we clean the teeth above and below the gum line. All we're really doing is removing plaque and tartar that are attached to the teeth and to the root surfaces. The problem with that is we just saw in the previous slide that some bacteria are actually tissue invasive. So we need to also do something to clean the tissue. The way that we can clean the tissue is we can use lasers, we can use antibiotics, we can use these little strips that stay, antibiotic strips that stay in the pocket. There's all different kinds of ways that we can clean the gum tissue. We also know from that previous test that some bacteria are actually resistant to the deep cleaning. So even though you're doing a deep cleaning on a patient and you're removing all the plaque and tartar, it's still not going to treat the infection. So that's why for all these years in history, people with gum disease end up losing their teeth. The number one cause of patients losing their teeth is not cavities. It's actually gum disease. And it's because in the past, we only did this one type of treatment, and the treatment, as we know, was not effective for most bacteria. So we have to have other stuff in our armamentarium that we can do to reduce these bacterial levels. This is the MMP8 enzyme test that I'm doing. So I joke with my team, it kind of looks like a pregnancy test. So you take these little litmus paper strips, you put them in the gum tissue, then you put the strips into this tube and mix it with saline solution. You let that sit for a couple minutes, and then you squirt out a little dot into the strip, and then you put it into this reader, and it'll read the test in about 4 minutes and then print out the results. What we're looking for is anything under 20. So if a patient has under 20 for their result, then what we know is that their MMP8 enzyme levels are normal, which means that the inflammation in their mouth is calm and the inflammation in their arteries and distant organ systems are calm. So this is actually one of my patients here. He was very, very excited about this because when he first got to me, he has arrhythmia actually in his heart. He was a patient of Dr. Balin Doneen. They sent him from Washington to come be my patient in Colorado. I see a lot of the patients now, which is awesome because several years ago I was just reading their book, so it's really cool to see this. So he came in, we did a salivary profile on him, and we did a genetic profile on him. And as we suspected, he had genetic mutations. So we know that he's already starting off from a predisposed inflammatory level. That's also why he has the arrhythmia. Every male in his family dies of arrhythmia as well, or dies of heart issues as well. So we treated him initially when we just had his oral bacteria profile and his genetic profile. And he came in for his maintenance cleaning, and he said, I want to do this new test you have to see, if I'm doing well. And we took it on him, and he got 23, which is actually very good. We'd like it to be 20 and below, but given his health history, I'm really proud that he's at 20. And then if anyone is between 20 and 60, that means that they are moderately elevated for the enzyme. Anything over 60 is severe. Just today, we had someone in our practice that was 315. She was a young 40-year-old female, thin, no other health conditions, nothing. So that's pretty scary when you get some of those numbers. And hopefully we're able to positively, improve her oral health, and hopefully that'll keep her from getting heart disease in the future. Because again, heart disease is the number one killer of women, especially. I mentioned this earlier, obstructive sleep apnea. So this one scares the crap out of me because this is a silent killer. 80% of people who have sleep apnea have no idea that they have it. Untreated sleep apnea is directly related to high blood pressure, heart failure, AFib, stroke, diabetes, depression. It's the major cause of auto accidents. And as dentists, we're constantly looking in the patient's mouth, so we have direct access to what their airway looks like. So if you look in someone's mouth and you can't see their throat, all you see is a tongue, that's a problem. They probably have sleep apnea. If you see that someone's grinding their teeth, that's what bruxism is called. They probably have sleep apnea. Same with acid reflux or GERD. Those are all signs that someone has sleep apnea. So I just wanted to show you a couple cases from my practice. So these are going to be the oral DNA cases. So I had a male come in. He was 25 years old, no medical history reported. We took his probing depth number. So again, we're measuring the tissue around the teeth, and we got some pretty deep pockets. So we got a 6 millimeter pocket, a couple 5 millimeter pockets, and a 4 millimeter pocket. And again, anything above 3 is cause for alarm. So we took his genetic profile as well as his bacterial profile. And what we found in this 25-year-old patient, right, who has no health conditions that he knows of, he has a homozygous mutation for interleukin 6, which means both sets of interleukin 6 are mutated. That puts him at an extremely high risk of inflammation. That means that just sitting down at night watching TV, he's inflamed. So that puts him at very high risk for heart disease, diabetes, arthritis, dementia, cancer, you name it. So knowing that, we also looked at his bacteria profile. And what you'll notice is he's under the threshold for all the different types of bacteria. But we know that this is the threshold of the average population, not the threshold of people that have the genetic mutation. So we have to be much more aggressive with him and his treatment to make sure that we keep his body as calm as possible. So what we did for him is we did the periodontal treatment, so a deep cleaning essentially. We used localized antibiotics and lasers to treat the tissue invasive and resistant bacteria. And then instead of having him come in every 3 months for maintenance cleanings, which is typical for patients who have gum disease, we have him come in every 8 weeks, just because we don't want to wait for that bacteria to get into the bloodstream and the gum tissue again because of his systemic genetic mutation. So case number 2, this one is a 27-year-old female. Again, no history of anything wrong medically. We took her gum measurements and found that she had 5, 6s, and 7s, which is pretty severe for a 27-year-old. So we wanted to see what was going on with her. So we did a bacterial profile on her. This was before they had the genetic testing option. And we found she was over threshold for all of the super scary bacteria. So PG, again, is associated with heart disease and Alzheimer's. TF and TD are associated with heart disease. FN, that's the pancreatic cancer, the stillbirth, and the colon cancer for FN. So we did the full periodontal therapy, the deep cleaning for her. We used localized antibiotics, lasers, and I also actually gave her a systemic antibiotic because I knew that her bacteria was in her bloodstream based on the levels. We also told her that because she has tissue invasive bacteria and bacteria that are resistant to treatment, that when she comes in, she should expect to also be treated with lasers every 3 months. Okay, so then after her initial therapy, we retested her again in 12 weeks, and we had already seen a reduction of close to 20% in just a short amount of time. So we know that she's on the right track. But you can also see that her low-risk pathogens actually went up after we retested her. So we still have some work to do with her home care so that she can get all the other ones down. But what was really great is that we lowered all of her high-risk pathogens in just a short period of time. So advice for future dentists. This field is always changing. Like I said, when I graduated 10 years ago, we knew that there was some sort of association between the mouth and the heart, but now it's coming out all the time of how much the mouth and your oral health affects systemic health. So be ready for it to constantly change. What you learn in dental school will not be how you practice. I will tell you that. And be ready to work hard. As dentists, we do have a great lifestyle. And we do have a good work-life balance. However, we need to make sure that we are there for our patients because we have a duty when we are going to be healthcare providers that we need to have access to care for our patients to actually help them get healthier. Always ask for feedback and find a mentor. You're in control of your own destiny. So surround yourself with the 5 best people that you can, or 5 people that you look up to or want to be like when you grow up, or become a dentist, and learn from them. This is another thing I always tell my team members, employees, my docs that work for me. I say, you are not growing unless you are uncomfortable. So do something every day that makes you a little nervous, a little anxious, and get uncomfortable, because it's the only way you're going to continue to improve and get better. This is another good little nugget. The size of the problem is related to the size of the potential. So if you're faced with something that seems insurmountable, that seems like you can't overcome it, really focus on finding a way to tear down that wall and overcome that obstacle, because the size of the problem is directly related to the size of the potential that you have if you move through it. I mentioned this earlier when I told you guys my story. Find your why, no, find your way. And just remember that the best is yet to come. Dentistry is an incredible profession. I started in 2010, which was just 2 years into the Great Recession. And it was great 10 years ago or 11 years ago, and it's only gotten better. You know, with COVID, a lot of dental offices were shut down because they didn't know how to handle COVID. I actually stayed open the entire time. I had the appropriate PPE. And what we found was that oral healthcare was so vital to surviving COVID and keeping COVID at bay. We knew that patients who got COVID who also had oral inflammation were 9 times more likely to die from COVID. So again, the bacteria in the mouth do not stay in the mouth. So I truly believe the best is yet to come. We're going to see dentistry and oral healthcare be completely integrated into medical in a few years. And I'm very excited for what we can do for our patients. So thank you guys very much. Here's all my social information. And then I just wanted to take some questions if anyone has any.
Thank you so much for the amazing presentation. I personally learned a lot, especially the different tests and just systemic health as a whole. So we do have some questions, and I can start by asking them. So you said that you were a partner of 84 offices. So how does that kind of look like, you know, managing them? What are your responsibilities? And like, do you visit them, or are they kind of dispersed throughout?
Yeah, I do visit them. I wish I had more time to go to all of them all the time, but I still practice full time. So it's a little bit insane, I'm not gonna lie. You know, I see patients full time and I still do that on the side. So I'm always available for texts, emails, phone calls to review cases. So I'm always on my phone, always on my email, trying to help the doctors. I have several days a month where I go out and I coach my doctors in the field to help them be more successful. And then I also work with the management teams to make sure that the offices are running productive and profitable practices. That's also why I partner with Pacific Dental, because they handle a lot of the management stuff. They'll provide me with the details of the practice, and then I can kind of analyze the numbers and what I'm seeing and give pointers from there. But it's a busy job. Most of my practices have been partnerships. So they're docs that I have taken on outside of school or whatever. We worked together for a while, and then they've gone off and opened up their own practice, and then I still partner with them in those practices.
That's super cool. So what's your like furthest office? Like, where is that, would you say?
South Florida.
Oh, wow.
Yeah.
That's so cool. So you mentioned that you were open for COVID. So how did you kind of see the number of patients maybe decline? And then when did you start seeing them go back up, and for what reasons? You know, like what was the main reason they were coming in? Just cleanings or checkups, or the inflammation you mentioned?
Yeah, so in the beginning, we were only allowed to see dental emergencies. So we weren't allowed to do cleanings, which was really frustrating me, because the number one high-risk patient for getting COVID and having adverse reactions were people who had heart disease and diabetes. And I was like, hello, that's directly related to the dentist. Like, we must be doing cleanings for these patients. Mm-hmm. But the government said no, we were only allowed to see dental emergencies. There was actually a massive increase in the amount of people cracking their teeth during COVID because of the stress. So I actually treated a ton of healthcare providers that were treating COVID patients, COVID positive patients, because they were cracking their teeth. So we were doing a lot of surgery during COVID because of that.
Gotcha. Wow, that's crazy.
Yeah, it was a little nuts. But as soon as the government, eased restrictions, depending on your state or local government, we saw a huge uptick. It was kind of crazy. Typically people hate coming into the dentist, but for COVID, it was like their escape, right? They couldn't leave their house, but they were allowed to go to the dentist, and now everyone wanted to come and see us. So it was quite busy.
So how many patients do you see a day, and how many dentists are at your office?
So I have 3 dentists at my office every day, and I see about 10 to 12 patients a day.
Oh, wow. So someone asked, do you ever encounter misogyny during dental school or as working a dentist, and how did you face that? And okay, yeah.
Oh, I'm so glad whoever asked that question, and I wish we had a whole presentation on this. Yes, you will experience it in dental school, and yes, you will experience it in the field from your patients, from your team members, and from other dentists. It is still shocking to me. I own a lot of practices, and I do a lot of implant surgery and complicated stuff, and I'll go to CE courses, continuing education courses, and I'll check in for the course, and the person checking me in will say, oh, what dentist are you here with, thinking that I'm their assistant or something. And so it's very frustrating that it still exists. We're in 2021 and it's still there. And there's a lot of stereotypes that we have to fight against, right? So as a female, if you have high expectations and put your foot down, you're considered 5-letter word? Yeah, 5-letter word, right? But our male counterparts, that's just, they're being a doctor. And so, so there is a lot of it that you will have to overcome. That's a big thing that I focus on my website, is coaching and mentoring females and how to navigate the system. And it's not easy to overcome, but it's doable. I think the first thing is to have security and have pride in that you've gotten this far, and that regardless of how they respond to you, you are who you are, and you've gotten here because you've earned it, right? We're facing an uphill battle, getting what we deserve. So don't let anyone take that away from you, right? You can't control how other people behave to you, but you absolutely can control your reaction. And so the best way I've been able to deal with it is to not even engage in it, because what Dr. John is doing over here has no effect on where I'm going, how I'm treating my patients, and what I'm doing in life. So you really have to I visualize it as I'm kind of like an energy field. And so when someone throws something negative my way, I just bounce it off the other way. So be self-assured and know it will come, unfortunately.
Gotcha. Thank you so much. So I think we have time for one more question. So there's a lot of patients that experience dental anxiety, and even with the pandemic, I think that fear has just gone up. So what are your tips on handling patients? How do you kind of go through the process, and what do you explain to them?
Yeah, so the best way, if you have an anxious dental patient, that's going to be someone who avoids the dentist at all costs until they have an emergency. Typically, by the time they get into your chair, there's lots of other things that need to be fixed as well. But just getting to the chair is a lot for them. They probably were up the entire night before. They probably haven't eaten all day because they're so anxious. So before I ever even talk about the teeth, I make sure that I find a way to connect with them. I share my personal experience with them. And I also let them know that before we even talk about treatment, we're going to talk about a way to make them feel comfortable while they're in the chair. And if we can accomplish that and they feel comfortable, then I'll talk about the treatment plan. So don't talk about teeth first with those patients. Connect with them on, share a personal story. If you have a family member that's anxious, or you're anxious, or whatever, connect with them that way. And then try and talk about how you can make them comfortable in your chair before giving them a treatment plan. I personally invested extra training in sedation dentistry. So I do a lot of sedation cases where I put the patients to sleep to do all their work.
Gotcha. Yeah. And do you offer them different levels of sedation, or
Yep. So I have the nitrous laughing gas sedation. That's the baseline. Then we can do Valium or triazolam halcyon. That's kind of like a twilight is what I call it. We can then mix the medication with nitrous, but they're still pretty awake. It's like, I tell them it's like having 2 or 3 glasses of wine, or I can put them fully under. Those are the bottles.
Gotcha. Thank you so much for the amazing Q&A session and presentation. We really, really appreciate it. And for everyone watching, make sure to follow Dr. Lee on her Instagram to kind of stay updated with like the new testing and just systematic health in general. But if that's it, thank you so much for coming.
I'm posting a lot of implant cases, videos and stuff from my implant course last weekend, so check it out.
Yeah. Bye.
All right, thanks. Bye, guys.